We can see it. Yep.
Okay,
Yes.
so I'm pleased to be with you today. I wish I could be there in person, but uh, that was not in the cards. So I'm going to talk to you about new options for ITP. I'm going to talk about research options in ITP, and some of these we'll talk a bit about more tomorrow. And I believe I think Wally will talk to you, or has already talked to you about anti-CD38 molecules. Probably the focus on DARA, but these are my disclosures. I work with many different groups that develop new therapies for ITP. And I'm going to give you my conclusions first, and then we'll delve into some of these things. I think that understanding the complex physiology of ITP guides new therapies. I think that the important thing is ITP has two different sides to it. It's a disorder of platelet production, and also a disorder of uh, platelet destruction. So I'm going to come back to these options in a second here. I'm trying to make my pointer work better than it usually does. So we've got TPO is a disorder of reduced platelet production. We have therapies, corticosteroids, and TPRA that work. I'll talk briefly about heterothrombopeg, which is a new TPRA, and hopefully I'm not going to steal too much from Ming's presentation. ITP is also a disorder of increased platelet destruction, and there's been a lot of work in developing new agents here. We have drugs that reduce anti-platelet antibody, anti-CD38s, daratumumab, mezagitamab, CM313. We have FcR inhibitors, which have been plus or minus recently. There's been a lot of excitement about BAFF and BAFF receptor inhibitors. I'll talk briefly about some of these. I'll talk to you about new IgG proteases, which you'll hear more about at ASH. I don't have time for CAR T cell therapy or the bispecific T cell engager therapies, some of which we're starting here in Boston with the T cell engagers and ITP. I'll briefly talk about sutimlimab and complement, and then I'll focus on several drugs that affect phagocytosis. I'll talk about sovleplenib, and then I'll concentrate a bit on rilzabrutinib, which is our new drug, which is recently FDA approved for ITP. So that's a rather modest agenda for the next 30 minutes to discuss this stuff. So again, I think John Semple probably showed this slide he always does about our dear friend Dr. Harrington showing that antibodies are in our circulation of ITP patients and drop the platelet count. These antibodies are of many types. We identify things by assays we know, but we don't identify things that we don't know. So I'm going to be cryptic here in saying we have tests against 1B9, 2B3A, and 1A2A, and we use these as we have done recently to look at the positivity of ITP patients. And ITP patients have, a high positivity rate of antibodies, oftentimes antibodies against all three major platelet antigens that we have tested for. What we haven't tested for are other antibodies that might also be causing ITP. So I present this slide with a grain of caution, simply implying that we know these antibodies are present. Whether they're etiologic or not comes back to what is ITP. And I'm certain at some stage we'll understand ITP. I frankly know less and less about ITP as the years go by. I'm waiting for John Semple to tell us what the real truth is. So these anti-platelet antibodies in animal models we know inhibit megakaryocyte platelet production. They also increase platelet destruction by binding Fc gamma mediated receptors and macrophages. So we can clear platelets with the antibodies in animal models. We can bind complement on platelets, and they may also cause platelet desylation. I've got a question mark here because I still have some major equivocations about the validity of that statement in human models. So let's start. This is a cartoon I've shown you all before. This is Dr. Provan making platelets in his bone marrow. They enter circulation. They're cleared by apoptosis after about 7 to 10 days, and he's got a normal platelet count. He's also a very muscular chap given the muscles we show here. If he develops ITP, his rate of platelet destruction rises, his platelet count falls, and we mark much of the destruction in the spleen, but also probably occurs in the liver and possibly other parts of our lung. For many years, we thought via Larry Harker that the body compensated by making more platelets in the bone marrow. This is probably not true in most patients, and we're left with a state of increased platelet destruction and an inappropriately low platelet rate of production. So this gives us a model for treating ITP, which you all know, which is either decrease the destruction or promote the production of platelets to give you a higher platelet count. That affects the platelet count. There are other aspects of ITP, such as fatigue and cognitive function, which may not be affected simply by these treatments. And this has left us with a repertoire of current therapies, which you all know. You can try to decrease IgG production with corticosteroids, azathioprine, cyclophosphamide, rituximab, and the new agent is rilzabrutinib, that we'll talk about. You can try to remove the major site of plated clearance, which is the spleen by splenectomy, or if you're in Japan, splenic embolization. You can try to block the FC-mediated clearance with corticosteroids, IVIG, danazol, dapsone, fostamatinib, and I've added rilzabrutinib here as well. Or you can increase the platelet production rate primarily by TPRA, but corticosteroids also achieves its effect in that fashion. So this is an overview of old therapies. I will briefly talk for 4 minutes on ITP as a disorder of reduced platelet production. And this comes to the fact that here's our lovely megakaryocyte, and it's being attacked by antibodies and probably also by lymphocytes of various types, undergoing programmed cell death and not making platelets. Uh, this is a cartoon that I've had for a number of years based upon data Lori Harker and I did 20 years ago. This is a bit of studies that ought to be amplified, but we do know from work by other authors that there are a lot of apoptotic megakaryocytes in the ITP bone marrow. And this has led to the use of drugs, corticosteroids, which I mentioned, recombinant human TPO, which is primarily in Asia, and the TPO receptor agonists. We know these three, rilzabrutinib, sorry, rimipilstim, L-trombopeg, and avatrombopeg. I'll briefly comment upon a new TPRA, heterotrombopeg, which may be working its way into the West in the coming years. So how do the TPRAs work? I described the megakaryocyte being attacked and undergoing apoptosis. Lori Harker many years ago with MGDF and recombinant TPO showed with us that if you add a thrombopoietic agent to a dying apoptotic megakaryocyte, it comes to the rescue, promotes cell viability, and the megakaryocyte, instead of dying, lives and makes platelets. So coming to therapies, we have a new therapy, a heterotrombopeg, which has been shown, and this is a publication, and there are several others. If you look at the number of CFU megakaryocytes in tissue culture, if you compare heterotrombopeg shown here to L-trombopeg with the same molar ratio, heterotrombopeg is probably tenfold more active on a molar basis than is L-trombopeg. It's a more potent molecule. It has most of the similar attributes. It's been studied by our colleagues in Asia. And basically, this is a nice ITP study looking at high doses of heterotrombopeg here, which a nice rise in platelet count, as you'd anticipate in a thrombopoietic growth factor experiment. And the platelet counts rose. Placebo patients had no response. And hence, this molecule is used commonly in China. I suspect Ming will discuss this in his talk later. I'm going to focus my attention on the novel agents which have attacked ITP by recognizing that it's a disorder of increased platelet destruction. So this is my favorite picture. It's a picture of a macrophage right here, my second favorite cell after the megakaryocyte. It's ingesting this platelet right here, which is presumably coded by antibody. This is from Sim Karpatkin from many years ago. And here's a platelet that's already been digested by the macrophage. So one of the ways to treat ITP is to make either the antibody coating the platelet disappear or to turn off the macrophage. And this leads to a whole cartoon of how one thinks about ITP. And I'm going to give you a cartoon network as to how these agents might work. If this is our platelet in our circulation, ITP patients make antibodies. And the first potential therapy for ITP is to make the antibody disappear. And there is a whole list of molecules that can do this. In the red are things we know work and we have available: splenectomy, corticosteroids, rituximab, and IVIG does bind and inhibit the neonatal FC receptor. But there's a whole list of molecules. There are several new CD20 molecules in the pipeline. I will talk shortly about anti-CD30 molecules. I will not talk about daratumumab, since Walid, I suspect, will talk about that. I will not talk about CM313, which is our Chinese friend's molecule. I'll mention TAC079 in some detail. Anti-CD40 molecules have been studied in a lot of different ways with little benefit. Immunoproteasome inhibitors do work, bortezomib being one of them, but this has not been studied aggressively. There's been a lot of work on inhibitors of B cell activation, either binding BAFF itself or inhibiting its receptor. We've got belimumab, and we've got the ianalumab. Remember that ianalumab is spelled with an I, not an L here. We have inhibitors of the neonatal FC receptor. We have IgG proteases, which I'll talk about briefly. And we have other B cell depleting therapies, which are bispecific T cell engager cells, which we are starting a patient on later this week, and CAR T cell therapy, which has been used more commonly in Asia and also in several sites in Germany. So, in terms of the cellular targets, and I'm going to just show you this nice overview slide that my friends at Uru gave me. We can look at the stem cell and the maturation of B cells. We have early B cells, more activated B cells, and then they become plasma cells like antibodies. This is a nice cartoon which reflects mostly bone marrow B cell maturation. And if you look at where CD20 hits in the green, it attacks in here, as the green line shows. The CD19 molecules will dig a little bit deeper into the pile and attack some plasma cells. The BAFF receptor molecules don't touch the plasmablasts or plasma or the antibody secreting cells very much. And CD38 molecules, which I will talk about, will primarily focus on the antibody producing cells. So let's start with BAFF, and I'm going to give you a teaser about BAFF, and we'll talk more about BAFF tomorrow. But BAFF is an interesting molecule, B cell activating factor for those of you that aren't aficionados of this lymphocyte sport. It's needed for the survival of most B cells, but not for pro-B, pre-B, or immature B cells. It primarily affects memory B cells. It binds to a receptor right here, has an incredibly complicated in the B cell effect upon the T receptor. So here's the B cell receptor over here. It has a number of molecules which it works. It interacts with the B cell receptor signaling pathway, but it's vital to maintain a B cell in viability. If you knock out BAFF in animals, the memory B cells are mostly affected. There's little effect on plasma cells. It's a very complex anti-apoptotic signaling mechanism. And BAFF, as was shown, and I'll show you the slide in a second, is elevated in many autoimmune diseases. Whether that is the cause of the disease or simply a reflection of the disease is a discussion topic for later. Again, as I said, here's the schema of B cell maturation, and the BAFF-dependent cells are here and later on in the maturation scheme. And finally, our dear colleagues in China have shown that BAFF is elevated in ITP patients, is back to normal in those in remission, and this is both true of the plasma BAFF level and the mRNA when quantified. So there's an increase in this molecule in circulation. This is true in almost any autoimmune disease, and whether it's causative or just a reflection of the underlying autoimmune disease is an interesting topic for speculation. You should read John Semple's nice review article in Blood from 2009. So I'm going to briefly finish on BAFF receptor molecules by saying that the ianalumab is an interesting molecule. It's an afucosylated IgG. It binds the BAFF receptor shown here, results in NK cell clearance of the B cell. It also inhibits BAFF by binding to the receptor over here and prevents B cell activation and hastens the death of many B cell precursors. So let's switch from BAFF, which we'll talk more about tomorrow, to CD38. This is a fascinating molecule. This is a molecule on sea urchins. It's shown here on a myeloma cell, basically. And this is the target for many myeloma drugs, as you all know. But this is an incredible protein. It primitively was developed as an NADase activity. It alters calcium flux in many cells. It's been appropriated by the immune system for many functions. It's an activator of B and T cell lymphocytes. If you have a loss of function mutation, you have an immune deficiency. And this makes it an ideal target for many molecules. More tomorrow. So in terms of the molecule we'll talk about today, mezagitamab, this is called TAK-079. This is a monoclonal antibody that binds to CD38, as I said, and basically it causes death of the CD38 containing cells. It targets plasma cells. It decreases IgG level in studies that I don't have time to present. This is our study with mezagitamab. Some of you participated in this. It's got part A and part B, but basically we're testing 3 different dose levels: 100 milligrams, 300 milligrams, and 600 milligrams versus placebo. It's weekly dosing for 8, an 8-week follow-up, and then a 16-week long-term follow-up. So I'm going to show you data primarily from a 16-week study, active therapy for 8 and 8 weeks of follow-up. The patients are shown here, and I'm going to focus on the placebo and mezagitamab combined groups just for the paucity of time here. They are rather young patients, 30 to 50, a little bit more women than men. These are patients who've had ITP for 11.3 and 10.8 years. These are really the refractory patients, although I don't like that word. Median platelet count is about 17 or 18,000, and they've had approximately four prior therapies for their ITP. If you look at the adverse event profile comparing the combined group placebo, combined group active therapy, adverse events were related to drug were about a third of all patients, very few serious adverse events. This was also done in the COVID era. Major adverse events are the ones we all expect in ITP studies, some injection site hematomas, and then the typical infections we see. There were no unexpected adverse events from using this molecule in our patients and no weird infections or thrombotic events in this patient population. And here are the platelet results. I will simply focus on what's called the platelet response. Did patients have a platelet count rise over 50,000 on at least two consecutive therapy weeks? And if you look at the placebo, I did that 23% of the time, but there is a dose-dependent increase in response with a 91% response rate at the higher dose level. Complete response, platelet counts over 100,000, 81%. So in general, there's a dose response curve shown here with increased response. These are the platelet counts, and this is what's striking. Placebo patients had a bit of a bump here, and we gave steroids for the first dose, but no steroids for the subsequent dose of the mezagitamab infusions. What was striking is that there was a little bump here in the placebo group, probably from the corticosteroids on the first dosing of the drug. The drug's given weekly for 8 weeks, but what was striking is in 2 days, most of the patients had a response. And you've got to ask yourself, if the goal of the drug is to decrease IgG, what's going on here? And the honest answer is we don't know. It goes back to the immunobiology of ITP. Is this all NK cell disease? And that's what we're targeting here. We know that NK cells disappear very fast in this situation. What's most striking about the study is if you look through week 16, 10 out of 16 weeks was the platelet count over 50,000 at the highest dose. This was a rather durable response. And what was even more striking is that the quality of life issues shown the pink. The pink is the mezagitamab group. This is the different domains of the study. This is also measured at week 16. There was a marked increase in all domains of quality of life, with the control group having a diminution or stability of these results. So things like fatigue and physical symptoms also markedly improved above the minimally effective important difference. Finally, what happened to the IgG levels? As I said, the IgG levels took a while to come down to the highest dose. They maintained a plateau of about 40% diminution by week 8. This is a little bit higher than you see with neonatal FC inhibitors, but the response occurred early, and it probably was not totally related to the drop in IgG, a topic for discussion. Now let's switch gears. We've talked about this before, which is the neonatal FC receptor. This is IgG. Here's the neonatal receptor binding here. And as you all know, this is a interesting molecule. It binds IgG on one surface, albumin on the other, and as the pH drops, the binding increases. So we have this interface here where it binds IgG, and this is the target for drugs. As drew Proven, this is a Provenism drawing. In normal physiology, here's your endothelial cells. They imbibe your plasma. The pH drops. IgG binds to its receptor. Other proteins in the green here are degraded. The endosome recycles to the surface, releases IgG, and the cycle starts over again. So if you inhibit the receptor with a monoclonal antibody or other things, you prevent the IgG here, both normal and pathologic, from binding. They are then destroyed, and you result in a decrement in IgG levels and hopefully the pathologic IgG. This is the structure of efgartigimod, FDA approved in the United States for several neurologic disorders and advertised every 30 minutes on our TV stations. It has been shown in ITP studies to drop the IgGs of all types. This is data from Adrian from a number of years ago. And when we do a clinical trial shown next, and this is the paper by Catherine Broom, This is the drop in IgG in a clinical trial of ITP patients. It drops by 60%. The CD38 molecule I showed you a minute ago dropped it by about 40%. There's no change in the placebo group here. And there was a modest rise in platelet count. Platelet counts rose by some 20,000 on average in active therapy versus placebo. And this was a positive study that we published a number of years ago. To my surprise and to my lack of understanding, and maybe someone in the audience does know the answer, when this was studied by a subcutaneous version of the molecule, which is approved for other uses in North America, the primary endpoint was not met, and nor then and the secondary endpoints met. This was a negative study. So I'm a little bit skeptical about efgartigimod right now in ITP, but it'd be nice to know why this study was negative. Switching gears to another new agent, which I'll briefly go over. When we have infections, bacteria are smarter than humans. They make enzymes that degrade IgG. So if you try to attack the uh, uh, infection with your antibody, the bacteria fight back with proteases. And one of these is called imlifidase, which is a recombinant protease from strep pyogenes. And it basically cleaves off IgG into half and destroys your IgG. And this molecule, as many of you know, has been shown in a lovely clinical study to drop your IgG from normal to 0 at hour 6, and then it comes back again. And this is patients who have high HLA antibody levels before the drug. These drop to low levels, allowing a transplant to ensue. Now, the problem with this drug is if you give one dose, you're highly immunized to it and it doesn't work. And this has led several companies, which we'll talk more about it at ASH this year with our abstract, to develop the wild type protease. You put it through an AI platform, and you can then get rid of the epitopes that make it antigenic. And so what you've done is created what's been called an invisible protease. And this has been shown to drop the IgG levels enormously down to 0 and persist by day 6. This was presented by us at ASH last year. You'll see more data with very prolonged depression times, which are dose dependent at ASH this coming year. So let's go on a bit. I've said that in ITP, if you can't get rid of the antibody, the next step is the antibody may bind complement. I say that with some equivocation, and then the molecule is decorated with complement, and it's destroyed by your immune system. So is there data? There's tons of data that complements on platelets. This is old data published many years ago that shows that you look at different complement bindings to control patients versus ITP patients. In general, ITP patients have more complement on the surface and more complement activation measured by their assays. The complement cascade I won't spend time on is very complicated, but you can bind an antibody here that activates the classical pathway. When you bind the antibody, the C1 complex binds, and we have developed a drug that many of you know called sutimlimab that inhibits the first component of complement. This works incredibly well in turning off the complement cascade in patients with cold agglutinin disease, as we've published. This is a study by Dr. Broom. If you give patients this drug with ITP, their platelet counts are low, you give the drug and the complement gets inhibited, as shown in the blue line here. Platelet counts on average rose. We then stop the drug in the gray bar here, complement levels returned, and the platelet counts plummeted. And this drug is no longer being developed by Sanofi for this indication. It's still a bit of a gray zone as to what to be used with, but there's an interest right now that's being rekindled for complement inhibitors in ITP. So if you can't make the antibody disappear or get rid of the complement, what happens next? It binds to the FC gamma R3 receptor, and it's internalized by a very complex pathway, which is dependent upon Syk kinase and Bruton kinase. It's internalized and destroyed. And this has led to a virtual industry of molecules that inhibit this process. In red are the molecules we know do this: corticosteroids, vincristine, vinblastine, splenectomy, fostamatinib, and the new drug is rilzabrutinib. There are things that are being studied, probably not much anymore, which is hypersialylated IgG. The recombinant FC multimers to give you a recombinant form of IVIG that are in limbo in terms of development. There is a new Syk kinase called sovleplenib, which I'll briefly present data on, and I'll conclude my remarks by mentioning the new drug, which is now FDA approved in North America, which is rilzabrutinib. So going back to the targets, we have rilzabrutinib and BTK inhibitors inhibiting BTK. We have fostamatinib, which we know, and sovleplenib that inhibits SYK. And these are the two targets that have been explored extensively by many different groups. So what is sovleplenib? Briefly, sovleplenib is an improved SYK kinase. It basically, this is the kinome map for fostamatinib. It hits many things on target and off target. The sovleplenib molecule is much more on target to SYK with very few off-target effects, meaning that it has many fewer potential side effects and maybe higher efficacy. In a very nice study in China, they gave this to ITP patients. Placebo group had no rise in platelet count. Those on active therapy had a typical response within a fortnight in raising their platelet count, and that persisted for the duration of the study. Equally important, if you look at other qualities of ITP studies that we all look at, did the rescue therapy need improve? Yeah, it decreased. Could you decrease concurrent corticosteroid therapies? Yes, they came off steroids or had their dose reduced quite nicely. And the WHI bleeding scores also decreased. And finally, looking at our standard of care these days, which is quality of life, there is a subtle increase in the purple here of quality of life that had some significance in two domains, physical functioning and energy. These changes in physical quality of life issues are probably not as marked as we saw with the CD38 molecules or with the rilzabrutinib molecules, which I'll describe next. Which brings us to Bruton kinase. It's important, since all of us know BTK inhibitors in CLLs, that things that help treat the CLL, to recognize that Bruton kinase inhibition is not the same as Bruton kinase deficiency. This is a thing I want to hammer in everybody's heads today, is if you don't have Bruton kinase at all and have X-linked agammaglobulinemia, you have no B cells, you have no antibody, you have increased infection, you have no autoimmunity, and you do quite well for your life by getting IVIG. Bruton kinase inhibition is totally different. It reduces BTK activity in autoreactive B cells. It reduces autoimmunity in many animal models. It has a minimal reduction in B cells. It minimally decreases IgG. It reduces inflammation, and there's a minimal increase in infection when these drugs are applied. So it's a different thing than knocking out Bruton kinase. So for those who don't know this molecule, this is Bruton kinase right here. It has multiple domains. Here's the one we target with inhibitors. It is an amazing molecule. The other domains we don't talk much about, but these are responsible for the myriad non-kinase effects of Bruton kinase. It is a very pleomorphic molecule and having many different domains with many different functions, which are yet to be explored. So we have been looking at Bruton kinase inhibition, recognizing that Bruton kinase is necessary for B cell activation, and if you inhibit it, you prevent B cell activation. We know that it inhibits macrophages quite nicely and decreases phagocytosis, and also in the inflammatory milieu, it will also turn off the inflammasome in many cells, decreasing the immune response and the inflammatory response. So what is rilzabrutinib? Quite specifically, it binds Bruton kinase here. It's got a very good off rate when it's not binding to BTK. This is a disulfide bond here. And unlike ibrutinib, it does not, which affects collagen aggregation, it does not affect platelet function. It has a very short half-life, but it has a prolonged inhibition of BTK. In animal models, here's the thrombocytopenic animal, here's the IVIG treated animal, and here's rilzabrutinib. It increases the platelet count. So we have studied the drug rilzabrutinib. I'm going to probably, just for the sake of time, skip to the phase 3 studies, which are most important. We have studied this drug in a randomized placebo-controlled phase 3 study comparing Bruton kinase 400 milligrams twice a day to placebo. This is a 2-to-1 ratio. These are ITP patients, 18 years or greater, with chronic persistent ITP, platelet counts under 30,000. This is a 24-week blinded study, a 28-week open label study, and an ongoing long-term many years extension study. In the blinded study, at 13 weeks, if patients did not have a platelet response with platelet counts over 50,000, they could enter the open label study. So This is a safety valve to avoid too long exposure in a 24-week study to a non-functional agent. So we're going to look at week 28 in these patients, asking was there a durable response, which means a platelet count over 50,000 on two-thirds of the last 12 weeks. So we got two response criteria, a platelet response over 50,000 by week 13, and a durable response, which is a highly restringent response for the study. Shown here, 133 patients given rilzabrutinib versus 69 on placebo. And to make this clear, these are bad ITP patients, median duration of disease of 8 and 6 years in the placebo and rilza groups. Median number of the therapies were 4 or 5, splenectomy in 28% of patients. If one enters the study and looks at the next 24 weeks, the median time to response on the rilza arm was 15 days, and 65% of patients responded. And those on the placebo arm, some patients rose their platelet count over 50,000, and this happened a third of the time, but that response was rather short-lived. So an early response in a high percentage of patients. The endpoint is shown here, and this is a highly stringent endpoint at week 25, and that's that 23% of patients had a durable response, which is two-thirds of the last 12 weeks had a platelet count over 50,000 versus 0% of placebo. Here are the responders, a nice rise, a rapid rise that was well maintained. If one looks at the long-term therapy, this is now a years-long study. Those that responded maintained their response. Half could discontinue their corticosteroids. A quarter could also discontinue concomitant therapy and maintain a response. The response was rapid. It occurred in a high percentage of patients, and many patients were on the drug with stable blood counts for a long time and came off their concurrent therapies. This is a data that Walid has presented. This is using a different response criteria, the IWG criteria, which is a little bit more liberal in terms of platelet response. This is a platelet count in the fine print here, over 30,000 and doubled from baseline without bleeding for half of the assessments during the double-blind 24-week study or the open-label study. And what Walid showed in this analysis of a study is that the response rates rise to 34% from 23%. And interesting enough, if you had fewer ITP therapies, that response rate was 41%. If you combine this is in the double-blind 24-week study, if you combine the two studies, open-label and double-blind, the response rate using IWG criteria is 50% and 64% if you had only one or two prior therapies. Adverse events rates were rather low, but what was interesting for this study was the quality of life fatigue issues. And fatigue in the 24-week study was markedly improved if you responded. You had worsening fatigue if you didn't respond. But what was interesting, if you got the drug and had a modest platelet count response, but not one that met the criteria, you still had an improvement in your fatigue level. And many patients who had a rather pathetic platelet count response had a marked improvement in fatigue, attesting to the off-target, meaning non-platelet effects of a BTK inhibitor. The fatigue levels over the long period of time, this is a number of years on study, this is month 12, and a year, 2.5 years later, the fatigue scores actually improved in patients returned in those who responded to normal in terms of fatigue level in this study. Finally, adverse events, I don't have time to comment upon, but the major point is bleeding effects infections were pretty much the same in active therapy versus placebo. Bleeding events are much less in patients on rilzabrutinib. And finally, rilzabrutinib is now FDA approved as of August, I think, 28th. It's now approved for patients with ITP who have failed other corticosteroid therapies. It's the same label in North America as the TPRAs, and the dose is 400 milligrams twice a day. So to summarize, ITP is a complex disease which I know increasingly less and less about as I study this more. New therapies will target platelet production, which is heterothrombopeg, but the major focus has been things that reduce antiplatelet antibody, that inhibit complement, and more recently inhibit phagocytosis. And there's a huge litany of molecules available for this, and I think that the introduction of rilzabrutinib to that armamentarium may improve our ability to take care of ITP patients. And on that, I'll stop and thank you for asking me to talk to you today.
Thank you, Dave. That's a really nice overview. Just while we're thinking, I was just thinking like destruction and production. On the production side, you can use a single agent and just boost platelets and not really care about what's happening. But on the destruction side, or the other side of the coin, single agents are unlikely to be that effective. And like complement, which may be involved in some patients, it won't be complement alone. It's going to be complement plus something else. You need an anti-complement plus an anti. There's something else. Do you know what I mean?
Yeah, I think right now what you mean is that we have gone from the age of single agents to we're going to become like oncologists and have multi-agent therapies. So I suspect as we learn more, we'll come to realize that no one drug is going to hit a home run for everybody. I think the
Yeah.
TPRAs are close to home runs. I hate to use baseball analogies in Europe, but if you, I do think that the TPRAs give you a very high response rate. But again, I think in the future we may be combining agents to give us a better therapy.
Yeah.
I think there are two directions in ITP, three directions. One is to get the count up, which is what happens with TPRAs that works for most patients. The second is to, in those that don't respond, to use combination therapy. And the third is, can you cure patients of ITP, which is the goal of us working on things like ianalumab or looking at things like mezagitamab that inhibits plasma cells. So I do think, can you cure ITP might be a nice topic for next year's conference.
I
But I
think
do think that we are switching from treating a platelet disorder to treating a syndrome, including fatigue and cognitive function, to trying to make the disease disappear. That's the trend line for this disease
I,
as we go
I
forward.
agree. I agree. Okay, Rick Kapoor has a question for you.
Hi, Dave. Nice talk. Thanks. Just wondering about the home run for the TPO-RAs, as you mentioned. So you show the data on the hetero thrombopeg that it's more potent, although we may not mechanistically understand why that is. But do you think we should also be investing in that? Because now it's China, right? That's utilizing it.
Yeah, I'm going to say that in a test tube, it's more potent, but whether you got to give, it's like blood pressure medications. Is you got to give the 1x dose or the 3x dose? If it just takes three times more drug to achieve the same effect, a more potent drug may not be any better. So I'm not saying it's a better drug, Rick. It has the same adverse event profile as L-trombopeg. I do think right now that it's more potent in the test tube. It's not been compared head to head with L-trombopeg in clinical trials, and the data that we saw that I presented is comparable to data that you would probably see with L-trombopeg or avatrombopeg.
Right. Yeah. Thanks.
So I'm not certain you buy much for the potency. It just makes it a different drug, and giving 30 milligrams rather than 90 milligrams may not be clinically important.
Okay, who else have we got? Waleed, you haven't said anything. That's unusual. That's unusual. Dr. Ganima. And then Dr. Gonzalez Lopez, you haven't said anything either. What would you like to say? Nope, nothing. Nope. Dr. Semple? Nope.
Clear as much. Perfect.
Yeah, perfect talk. No, it's a really interesting area. Frustrating, but interesting. A whole raft of new medications, but not knowing quite when to use them and what combinations. And
I have a question for the audience, Drew.
Carry
Question
on.
audience says, I showed you the CD38 data with this rather rapid rise in platelet count that occurs at day two in most patients. And this is a drug that targets IgG to decrease, but the IgG levels haven't dropped. What do people think is the mechanism of platelet count rise at day two with an anti-CD38 drug? It can't just be a drop in IgG.
Dr. Semple knows the answer to this one. Have you got a mic? Hold on. Wait for a microphone so you can hear.
I think it's the natural killer cells that it hits and kills them by complement.
So, John, I agree with that. And the NK cells disappear within hours of getting an anti-CD38 drug. But how does the NK cell causing the thrombocytopenia? Is it a direct effect on platelets? What do you think is going on there?
ADCC against the megakaryocytes and/or the platelets themselves. I would think more of the megakaryocytes.
And I agree. It's hard to study these things in a human because you're not doing serial bone marrows on these patients when you give the drug.
Haven't done CD38 in the mouse.
Say that again?
We haven't done CD38 in the mouse yet, so it'd be a perfect way to look at it.
You need small bone marrow needles, John.
Any more while we have him on the line? Any other burning questions for Dave? If not, I'll just say thank you, Dave. Really nice talk. As always, a pleasure to have you. Thank you so much for taking part.